Hi, everyone. My name is Matt Goldman. I'm the Medical Director for Crisis Services for the San Francisco Department of Public Health. There you go. And I'm going to be talking to you about expanding the evidence for crisis services, a path forward. The path of being in a mental health crisis is a long and a windy one, and it's up to us to make sure people in crisis get the highest quality care possible. I was a psychiatry resident when I first worked on a mobile crisis team, and I so vividly remember visiting a patient in suicidal crisis, who here we can call Frank. It was so powerful to meet Frank where he was at, in his home, on his terms, surrounded by photos of his loved ones. This is so different from the fluorescent lit hospital rooms that I was used to working in, and I wondered constantly, why don't we do more of this? And what are the best practices that I should follow when I'm caring for someone like Frank? These are complex questions, and it turns out we don't have many easy answers. If Frank were to have called the National Suicide Prevention Lifeline, which will become 988, we know that hotline counseling has a strong research base to guide the de-escalation and suicide prevention interventions that can best keep him safe. But what if Frank was calling because he had just relapsed on heroin? Or because he was hearing voices, or was in some other type of mental health crisis, the worst day of his life? We do not yet have research to support best practices in those scenarios. If Frank was in a crisis that required an in-person assessment, research studies have told us that a mobile crisis team would be more likely to help him avoid going into the hospital than if he were to go to the emergency department, and he'd be less likely to be arrested than if law enforcement had responded to see him. But what's the optimal configuration for mobile crisis teams in terms of co-responder models, involuntary versus voluntary treatment, clinical pathways for various presentations and populations? So far, these studies have not been done. If Frank needed additional support in a crisis facility, we know that crisis residential treatment has better client satisfaction and lower costs than inpatient treatment. But how effective are peer support models compared to medical models? What are optimal lengths of stay to help resolve most crises, rather than being constrained by an arbitrary 23-hour limit set by regulators and payers? And what about cross-cutting questions like best practices for providing follow-up care post-crisis? How should services be adapted in urban versus rural settings? Which practices are most likely to divert people in crisis from getting arrested and put in jail? And do these services actually reduce disparities and advance equity in access to mental health care? Rarely have these questions been studied, perhaps due to stigma or lack of services research funding, or because these questions are complex and there are no easy answers. But we need research to support crisis program design as well as clinical best practices. It would never fly to allow emergency interventions for heart attacks based solely on anecdotal evidence. We owe it to our vulnerable patients like Frank to make sure that we're serving them in the best way possible. So where do we go from here? The implementation of 988 and the groundswell of investment in crisis services means there are countless new programs that can be studied to expand the evidence base. This is a once-in-a-generation opportunity, but this work won't happen on its own. It will require an organized national effort to move us down the right path. I believe there are 5 key strategies to make this happen. Develop a crisis research agenda, align quality improvement and research activities, build data infrastructure, improve data collection on race and ethnicity, and foster a community of crisis data experts. So first, a research agenda. As I've described, there are so many gaps in the evidence base for crisis services. Programs across the crisis continuum all need additional research on clinical best practices, as well as guidance on ideal models at the program and service system level. So there's a need for subject matter experts in behavioral health, emergency medical services, criminal justice reform, social determinants of health, and other ally fields to convene and develop a crisis services research agenda to guide the field and include direct input from people with lived experience of mental health crisis. Second, align quality in research. Local health officials and academics often work in silos. I have known more than one administrator who instantly fell asleep upon hearing the word research. But quality metrics and implementation science outcomes are more alike than they are different. We don't only need randomized control trials. There is a need for consensus around quality metrics and benchmarks, and research can help. Community-based participatory research can inform science and services alike. Patients, payers, and policymakers all stand to benefit from advances in crisis services research. Third, data infrastructure. Relevant information exists in many types of databases. We've got clinical electronic health records, ambulance run logs, police reports, insurance claims, death records, and many more. But linkages between these data rarely exist in the ways that are needed to support robust quality improvement and more rigorous research. So there's a need for investment of resources and analyst expertise to develop data infrastructure that can be used in both quality and research activities. For this to be possible, we must advocate for smart and sustainable approaches to reporting and evaluation requirements in federal and state legislation and funding initiatives. Fourth, data on race and ethnicity. Incomplete ethno-racial data makes it impossible to conduct equity studies. What disparities need to be addressed by a crisis system? Does implementing crisis services perpetuate, worsen, or dismantle structural racism and entrenched inequities? Without race and ethnicity data, we'll never know. So to improve this kind of data, evaluators can provide specialized training to clinical staff on how to collect sociodemographic data, which may be understandably challenging in the midst of a crisis. Linking clinical records to other databases with more robust race and ethnicity data is another strategy. Fifth and finally, foster a community of crisis data experts. Although this work has been challenging to advance for all the reasons I've described so far, some researchers, some of whom are sitting in this room, and quality experts have been doing this for years and have many lessons learned to share with colleagues in the field. There is a need for a network of experts to share best practices for implementation science methods to study these real-world models, promote research funding opportunities like grants and RFPs, requests for proposals, disseminate crisis research articles and presentations, and advocate for funding to support this work. 5 strategies to advance crisis research and evaluation. Develop a crisis research agenda, align quality in research, build data infrastructure, improve race and ethnicity data, and foster a community of crisis data experts. These are starting points to expand the evidence base for crisis call centers, mobile teams, crisis facilities, and post-crisis follow-up. We can do this together. Someday, we'll rest easier knowing that Frank is getting the best care possible at every turn. Thank you.